Hi, welcome to the next session of the virtual 2020 American Society of Head and Neck Radiology annual meeting. We are fortunate enough to have a fantastic lineup of speakers for this next session, which is a core curriculum session on the head and neck spaces, anatomy, and pathology. My name is Nick Kuntz. I'm a neuroradiologist and head and neck imager at Indiana University School of Medicine, and I'm dressed up wearing my blazer top and shorts for this component of today's lectures. And I'm joined by my lovely colleague.
Good morning. I'm Karen Salzman from the University of Utah. Welcome, everyone.
First of all, we'd like to extend a great thank you to Dr. Ilona Schmalfus, as well as the rest of the program committee for putting together such a fantastic program for this year's ASHNR virtual meeting. Certainly, there have been a lot of challenges, as we all know, but we have a fantastic lineup of speakers. Our first will be Dr. Richard Wiggins, who is the Director of Head and Neck Imaging, as well as the Associate Dean of Continuing Medical Education at the University of Utah. Dr. Wiggins, as we all know and love, is a Texas Cajun head and neck radiologist and former president of the American Society of Head and Neck Radiology, and he'll be speaking on the topic of fascial anatomy of the head and neck.
Well, hello there. This is Rick Wiggins from the University of Utah. And today we're going to talk about the fascial anatomy of the head and neck. Nothing significant to disclose. Frankly, I really thought as I got older the world would make more sense to me, but it seems like the opposite is happening. So our objectives, we're going to talk about the fascial anatomy of the head and neck, and we're going to see how this fascia divides the extracranial head and neck into spaces, and we can think about what normal anatomy lives in each of those spaces and see how we can make a space-specific differential diagnosis based on this anatomy and those fascial layers. Now, the anatomy of the extracranial head and neck is very complicated. We often think about this as triangles from the anatomy aspect or layers, but on cross-sectional imaging, we may think about spaces. And in fact, if we look at anatomy books, we can get an idea of the very different ways to think about all these layers and spaces and everything else. And a lot of the anatomy books from the 1600s and 1700s discuss the anatomy this way, like in an operating room or in a gross anatomy lab, with the sternocleidomastoid muscles and the trapezius making all these spaces of triangles around the head and neck. But in the 1800s and 1900s, we started to see articles that describe these layers as fascial layers and spaces. And I actually had the great opportunity in the early 90s to do a year of research on head and neck anatomy and imaging anatomy with program chair and president-elect Dr. Ilona Schmalfus. And you may be surprised to see that she looks the same about 30 years later. So you may want to ask her, what's up with that? But we all looked at these anatomy books, and a lot of us had kind of favorites. I had my own favorites. That was Grudinsky and Holyoke, these guys from Nebraska, because they had this great article and papers that came out with these line diagram cross-sections through the extracranial cervical soft tissues that described the neck as these spaces and fascial slips. Now, as we looked at this anatomy, especially in the gross anatomy lab, everything it seemed like was upside down, so we had to turn it around. But I spent a lot of time on an old Mac SE30 Plus and Adobe Photoshop 1.0 cleaning up these images. But it was a great experience for me because it gave me the opportunity to really think about these fascial layers and these spaces and how they separate and define the extracranial head and neck. So we have fascial layers that are around the upper digestive tract, and then we can divide up the rest of the cervical soft tissues and the suprahyoid and the infrahyoid neck. For the upper digestive tract, we have the nasopharynx up high, the oropharynx in the middle, and the hypopharynx down low. And there is a fascial layer that is around and separates this area. And we think about that upper air digestive tract as being these well-defined little areas that are especially important for tumor staging. Where we say the center of a tumor is, like squamous cell carcinoma, is very important in the staging system as well as therapy and treatment of that patient. So if we say a lesion, for example, is centered in the nasal cavity or the nasopharynx or the oral cavity, the oropharynx, the larynx, the hypopharynx, the trachea, or the esophagus, wherever we think that's actually centered in the upper digestive tract is very important for their staging. When we think about all the soft tissues that are around the upper digestive tract, we can think about these spaces in the suprahyoid and infrahyoid neck. So if I find that hyoid and I just draw lines straight across, that separates from me the suprahyoid and the infrahyoid neck. And we think about cross-sectional imaging very different than we think about these fascial-defined boundaries. In gross anatomy and in surgery, we think about triangles. But if we're looking at cross-sectional studies, CT and MRI, we want to think about these spaces. So we're going to go through and talk about these spaces, and we're going to look through it on graphics, and we'll look at how CT and MRI help us differentiate these spaces. So first, we have the superficial cervical fascia. This is just a thin layer of the subcutaneous tissue that's between the dermis of the skin and the deep layer of the deep cervical fascia. We sometimes refer to this as the SMAS, the superficial muscular aponeurosis space, or if you're talking to a plastic surgeon, they may describe it as the SMAS, the superficial muscular aponeurosis system, all the voluntary and involuntary muscles of facial expression, and the subcutaneous fat that's around them. So they can be especially important if you're in an area where people are injecting or getting a lot of cosmesis placed within that subcutaneous tissues. But we can think about that as mostly the platysma and all the subcutaneous fat that is around the extracranial head and neck. So that's the superficial cervical fascia, all the subcu fat that is between the dermis of the skin and the deep layer of those cervical fascia. Now, the deep layer of cervical fascia we think about is separated into three main big areas. There's a superficial layer, the deep investing or the investing fascia that we see here in yellow. Then we have a middle layer, the buccopharyngeal fascia. That's the pink or fuchsia here that's around the upper digestive tract. And then we have the deep layer or the perivertebral fascia that's around the vertebral body and all the paraspinal muscles at that layer. So this is a section in the suprahyoid neck. And again, we see the superficial layer in yellow, the middle layer here in pink, and the deep layer in blue. And these cervical soft tissue fascial layers define these spaces, and some of them are kind of like tubes that extend through both the suprahyoid and the infrahyoid neck, so they may direct pathology superiorly and inferiorly in that space. And if we look at the infrahyoid neck, it's the same way. So here in yellow, we see that superficial layer or the investing fascia that's around the SCM and some of the strap musculatures anteriorly. The middle layer, the buccopharyngeal fascia, is again kind of around the upper digestive tract. And the deep layer, or the perivertebral fascia, we see around the vertebral bodies and all those paravertebral musculature. Now, we see here, if we look at that middle layer again, that we see a close-up of what we can call the visceral space. So that is only in the infrahyoid neck, and that's the middle layer of the deep cervical fascia and the infrahyoid extracranial soft tissue. So we've got the thyroid there, the trachea, the parathyroid, and the esophagus down low at that level, and we have the larynx up higher. Now, in between the investing or superficial layer and the deep layer, or the perivertebral, we have this fat that's kind of deep to the SCM that we can call the posterior cervical space that's around there. So that's a space that's in between the superficial layer of the deep cervical fascia in yellow and the deep layer of the deep cervical fascia that's in blue here. So we can think about that as all this fat that we see down low in between the SCM and the trapezius. That's the posterior cervical space. And if we have a generic lesion at that level, we can see how that pushes that SCM out laterally, pushes the carotid and the jug here anteriorly, and it's going to be out lateral to that perivertebral fascia that's around the vertebral bodies. Now, if we have a really bad trauma patient and we have diffuse subcutaneous air that's tracking up, for example, from bilateral pneumothoraces, and somebody with a lot of blunt chest trauma with multiple rib fractures, we can actually see the air dissecting up around these fascial slips and into these spaces. So we can get an idea of where all these spaces are if we ever see a case with a lot of dissecting air like this one. And we know that there is some variability of these fascial layers. They're not complete all the time. There's often holes, and we're reminded of that here in these cases with diffuse dissecting post-traumatic air. We know that there are connections between these spaces, but they're a relatively good barrier for things like infection and disease. So we can think about the suprahyoid and the infrahyoid neck in terms of these spaces that are defined by those fascial slips. So in the suprahyoid neck, we have these lateral spaces, parapharyngeal, pharyngeal mucosal, masticator, parotid, and carotid spaces. And it's our job to try to think about these and give the surgeon some idea of where they're going and what they're after. We want to help these guys before they get to the operating room understand the anatomy in a cross-sectional area. So I'm going to take this same axial T1 image without contrast, and I'm going to outline all of these spaces for the suprahyoid neck. We're going to look at graphics, and we're going to look at CT and MRI of this anatomy and talk about what lives in each of these spaces as we go through the extracranial head and neck. So first, we have the parapharyngeal space, and I'm going to outline each of these spaces here. So here's this triangle of parapharyngeal fat that's on both sides of the upper air digestive tract. It's kind of complex fascial slips, but it is the parapharyngeal space. So it's pretty easy to identify, and it's especially important if we're looking at a CT to be sure we window it so that air is different than fat, so we can see that fat at the parapharyngeal space. Now, normally there's just fat in this location, but it's important because that parapharyngeal fat is a little attachment at the skull base and goes down and dumps into the submandibular space. And we know that the submandibular and sublingual spaces kind of connect in the back to that parapharyngeal space behind the mandible. Up at the skull base, there's just a small connection at the central skull base for the parapharyngeal fat. And it's usually not very exciting, except if we look at how that parapharyngeal fat is displaced, it helps define the space origin of a mass in the suprahyoid neck. So that's very important for us. We find how the parapharyngeal fat is displaced, and that helps us make a space-specific differential. So now we'll look at all the spaces that are around the parapharyngeal fat. So first we have the pharyngomucosal surface or space here in blue. So that's part of the upper air digestive tract. We've got the mucosa of the upper air digestive tract here. We've got some lymphoid tissue, some minor salivary glands. This is really where squames live, where squamous cell carcinomas live. And that's going to go from the skull base all the way down along the upper air digestive tract with a little abutment of the sphenoid sinus. So here's that same axial T1 image, and here I've outlined for you the pharyngomucosal surface or space. Now you see where it is medial to that fat. So if we have a generic lesion of the pharyngomucosal surface or space, it pushes that parapharyngeal fat posteriorly and laterally, helping me guess that the lesion is arising from that mucosal surface or space. Now lateral to that, we have the masticator space. So here we have part of the posterior mandible. We have the muscles of mastication with the masseter, the medial pterygoid, the lateral pterygoid, a little bit of fat, and importantly, we have cranial nerve V3 that's going through there to enter the mandible and supplying the muscles of mastication. And the masticator space has these different segments we sometimes talk about. There is a part above the zygomatic arch. So there's a suprazygomatic masticator space, and there's an infrazygomatic masticator space, or the temporal fossa and the infratemporal fossa as these different areas. And we see here cranial nerve V3 going through that space to enter the mandible from ovale through the masticator space between the lateral and medial pterygoid. So here's that same axial T1, and here I've outlined for you the masticator space. So we see where that is in relationship to that parapharyngeal fat. So if I have a generic lesion of the masticator space, it's going to push that parapharyngeal fat medially and posteriorly, helping me guess the lesion is arising from that area. And again, it's very important here that we remember that we have the cranial nerve V3 that's going through that masticator space. That is a very important potential route of perineural tumor and a key mechanism of spread from the mandible to get up intracranially. Now, posterior to the masticator space, we have the parotid space. So we have the parotid gland here, we have the facial nerve, we have a bunch of lymph nodes that are within the parotid. We have a big vein behind the mandible, the retromandibular vein, and we have the external carotid artery branch that goes up to the superficial temporal. We sometimes talk about the parotid as being superficial and deep lobes on cross-sectional imaging by designation of separation for where the facial nerve goes through the parotid, but embryologically, the parotid doesn't really have a superficial or deep lobe that are separate embryologic on logons. We just use that definition to be separate of where the facial nerve is to a superficial and a deep lobe. And if you can't see where the facial nerve is, you can find that retromandibular vein, and we know the facial nerve goes just lateral to it. So for us, that's going to separate the parotid into a superficial and a deep lobe. So here's that same axial T1, and here I've outlined for you the parotid space with the parotid gland at that area. Now we think about the parotid as a nice little triangle here behind the masticator space, but in reality, there's accessory parotid tissue that goes superficial to the masseter sometimes along the course of the parotid duct, where it pierces the fascia over that second maxillary molar tooth and goes through the buccinator. So we remember that the parotid may have accessory parotid tissue superficial to the masseter muscle, and this might be all of the parotid tissue. We might not see any in the parotid bed itself. We might only see parotid tissue here. So here nicely on the CT and on this MR, we see correlating cases that have accessory parotid tissue extending along the parotid duct. So any pathology that happens at this location can happen along that accessory parotid tissue. So we like to think about the parotid as a nice triangle here behind the mandible and the muscles of mastication, but we do have this accessory tissue in that area. So we also think, just importantly, we remember that V3 is coming out ovally to go to the masticator space. We have the stylomastoid foramen between the mastoid and the styloid process where the facial nerve is coming out, and the parotid has this attachment at the skull base between the styloid and the mastoid process. And so we remember that we have this attachment up at the skull base from the suprahyoid neck cervical soft tissues, and we see where that is in relationship to the parapharyngeal fat medially. So if I have a generic lesion from the parotid space, I know that that's going to push the fat anteriorly and medially, helping me guess that lesion is arising from the parotid space. And again, I can think about what normally lives there, the parotid gland, all these lymph nodes, parotid tissue, the retromandibular vein, the facial nerve, and I can think about what pathology happens to that anatomy. Now, also important in this area, we have some spaces that are usually very boring, except when they're very exciting. One of those is the retromaxillary fat pad, especially with perineal tumor spread. We normally just have fat behind the maxillary sinuses, but we can have perineal tumor spread from the pterygopalatine fossa go down into this area, or go from the retromaxillary fat pad up to the pterygopalatine fossa. So that's the retromaxillary fat pad. And we also have a buccal fat pad that is actually in front of the muscles of mastication and the masticator space. So the little bit of fat we think about between the masticator space and the parotid duct, we sometimes call the buccal fat pad. It's usually very boring, except when it's very exciting, especially with retromandibular tumors. If we have a retromolar trigone tumor that may be crawling up the pterygomandibular FA, it may go up into that buccal fat pad and replace the normal fat at that location. So if we're thinking about retromolar trigone tumors, we pay attention to that buccal fat pad to see if it's involved. So that fat is kind of in between the muscles of mastication and the parotid duct where it goes anteriorly. So next we have the carotid space, or the carotid sheath. This is kind of complex in terms of the fascial anatomy. All three of those fascial slips are thought to combine to make that carotid space or sheath. And we've got the carotid here, we've got the jug, we've got parts of cranial nerves 9 through 12, and we think about lymph nodes being associated with this space at that level. So here's that same axial T1 image, and here I've outlined for you the carotid sheath or space. And we see where that is immediately posterior to that parapharyngeal fat, that triangle of fat in the suprahyoid neck on both sides. This has an extent superiorly and inferiorly through both the suprahyoid and the infrahyoid neck, and we see how in this graphic the styloid process kind of separates the parapharyngeal fat from the carotid sheath or space. So if you ever hear this discussed as the post-styloid or retrostyloid parapharyngeal space, that's why the nomenclature some people use for this area. But I've never liked that personally because sometimes pathology in the retrostyloid or post-styloid space is in front of the styloid process, and sometimes pathology in the pre-styloid space is technically behind the styloid process. But whatever words you're using for your surgeons, just as I said at the beginning, we have a lot of anatomy books that describe this anatomy differently. Whichever words you're using are great as long as your referring clinicians understand what those words are. So that styloid process we think about is separating these two spaces. And if we see a heavily calcified stylohyoid ligament, we can think about that again and running through the suprahyoid neck and separating those spaces at that level. So that carotid sheath or space extends from the jugular foramen all the way down to the aortic arch. And again, we've got the carotid here, we've got the jug, and we've got lymph nodes that are associated with this area. And there is some variability. We see here in this graphic an example of kind of kissing carotids. Those two tubes may go to the midline and they may shift around, especially on Valsalva if you look closely on imaging. If we do have a generic lesion, though, of the carotid sheath or space, we see how that parapharyngeal fat is pushed anteriorly and medially, helping us guess that that lesion is arising from that location and that space. So those are the lateral spaces in the suprahyoid neck. We have two big posterior spaces that we talk about, the retropharyngeal space and the perivertebral space. In between them is the danger space. We sometimes think about this as a potential space. That usually there's not anything exciting there, but there can be something very exciting, especially if we have infection that may extend down to the mediastinum, or pathology from the mediastinum that may extend up superiorly. And the perivertebral space, that blue fascia layer, the deep cervical fascia that goes around the vertebral body, touches the transverse process on both sides and goes back around the spinous process and that musculature. When it touches the transverse process, it kind of divides up the perivertebral space into a prevertebral portion with those anterior prevertebral muscles and a paraspinal portion with the posterior musculature in the back. If we look closely at this anatomy, we see that there are fascial layers that define this area. So if we zoom in here, we see these fascial slips that are between the airway and between the vertebral body. So is this behind the airway? Yes, that is kind of retropharyngeal. And is this in front of the vertebral body? Yes, that is prevertebral in that sense, but we can define these spaces a little bit better. We have the retropharyngeal space, the space that is behind the upper air digestive tract, and we have the danger space, that potential space back behind it where there's a little bit of fat. In between those two spaces, we think about the alar fascial layer, the slip of fascia that separates them at this location. So again, we have the middle layer of the deep cervical fascia here in purple, the buccopharyngeal fascia that's around the upper digestive tract. Then we have the perivertebral fascia that's around the vertebral body and its musculature. The alar fascia goes in between those two and goes over to kind of touch or go near the carotid sheath or space, and that separates the retropharyngeal space from the danger space. And we remember that danger space, somewhere around T3, has a trap door where pathology, especially retropharyngeal abscess, may extend down into the mediastinum, or disease from the mediastinum may extend up. So the retropharyngeal space in front of that alar fascia goes down from the skull base, and somewhere around T3, where that trap door is, we think about that stopping at that level, the retropharyngeal space. So we have a difference in that retropharyngeal space in the suprahyoid neck, where we think about fat and lymph nodes, and the infrahyoid space, where we pretty much just have fat, usually at that location. So the retropharyngeal space below the hyoid is just fat, but above the hyoid, we can have fat and lymph nodes. These lymph nodes are very important in some pathology, especially nasopharyngeal carcinoma and thyroid with differentiated thyroid carcinoma, which pays no attention to the normal lymphatic drainage we think about with squamous cell carcinomas that are generally moving down and towards the heart. So here's that same axial T1 image, and here I've outlined for you that retropharyngeal space. So we have this space that is posterior to the airway, and it is in front of the vertebral body, but we can differentiate sometimes what is retropharyngeal and what is prevertebral in that sense, if we think about these fascial layers. So that trapdoor somewhere around T3 is a very important conduit potentially for infection. But remember these lymph nodes that may show up in the suprahyoid neck and the retropharyngeal space. So if I have a generic lesion of the retropharyngeal space, I see where that is in relationship to the longus colli and capitis musculature, those muscles that are in front of the vertebral bodies. It's going to be in front of those vertebral bodies. So that helps me define this space as the retropharyngeal space. So next we have the perivertebral space. And again, we think about this as having different portions, a prevertebral portion in front of the vertebral body and a paraspinal portion posterior to the vertebral body. To the surgeons, this is the carpet. It's very important for the posterior wall of the upper air digestive tract if we have tumors there that we think are invading in that prevertebral space. That is the carpet to the surgeons, and if it's invading that space, it may not be a very good surgical candidate anymore. So it's our job to try to tell them if we think tumor has invaded the prevertebral portion of the perivertebral space. And again, we think about this a little bit differently in the suprahyoid neck versus the infrahyoid neck. In the suprahyoid neck, we think about those few muscles that are in front of the vertebral body and the large bulky muscles posterior to the vertebral body. But in the infrahyoid neck, we have the brachial plexus coming out in between the anterior and the middle scalene. the little phrenic nerve and that musculature at that level. So when we think about differentiating these spaces, we remember that those fascial slips kind of go around the vertebral body of that musculature and the suprahyoid neck, but we see that the prevertebral portion looks a little bit larger with the brachial plexus and the scalene musculature and the infrahyoid neck when we think about the perivertebral space. So in the suprahyoid neck, we think about the prevertebral portion as mostly the prevertebral muscles and part of the vertebral body and the vessels, with the posterior portion, the paraspinal portion, is just the paraspinal muscles and the posterior elements of the vertebral body itself. But if we go down in the prevertebral portion in the infrahyoid neck, there's going to be more soft tissue here at that level. We're going to include the scalene muscles, the brachial plexus, and that little phrenic nerve that's sitting on top of them at that area. So the prevertebral portion of the perivertebral space is larger in the infrahyoid neck than it is in the suprahyoid neck. Now, if I have a generic lesion of the perivertebral space, again, I can find that longus coli or capitis musculature, and I see how it's lifted away from the vertebral bodies in this graphic and the correlating case, helping me guess that this lesion is arising from the perivertebral space, not the retropharyngeal space. So we have all these fascial layers that are in the suprahyoid and the infrahyoid neck, and we can think about in the suprahyoid neck, we have these lateral spaces and we have the posterior spaces. The lateral spaces are all around that parapharyngeal fat. And we remember, again, the masticator space has a suprazygomatic masticator space and an infrazygomatic masticator space. So we have some spaces that are directed like tubes in both the suprahyoid and the infrahyoid neck. So we have the carotid space, that retropharyngeal space, and the danger space, as well as the perivertebral space and the posterior cervical, kind of the space we think about between the superficial layer of the deep cervical fascia or the investing fascia and the perivertebral or the deep layer of the deep cervical fascia. That is the posterior cervical space. So when we do have a lesion of the suprahyoid neck, we think about its effect on the parapharyngeal fat, and that helps us assign a space of origin. And then we can make a space-specific differential based on what pathology happens to that anatomy. So for each suprahyoid neck mass, I'm going to think about where the parapharyngeal fat is normally. And if the lesion looks like it's arising from the pharyngeo mucosal surface or space, it's going to push that fat laterally and posteriorly. If the lesion is arising from the masticator space, it pushes that fat posteriorly and medially. If it's arising from the parotid space, it pushes the fat medially and a little bit anteriorly. And if the lesion is arising from the carotid sheath or space, then it pushes that parapharyngeal fat anteriorly. So I can find the fat, I can think about how it's displaced, then I assign a space origin of the lesion, and I can make a space-specific differential based on the imaging characteristics, and I think about what pathology normally happens to that anatomy. Same thing in the posterior suprahyoid neck. I can find the longus coli and capitis complex and think about how it's affected by the pathology to help me guess that space area. So I think about it like on this axial CT, and I want to window it so that air is different than fat, so I can see where there's air and where there's fat. So it's important to start looking at a soft tissue neck CT with a window level something like 440, but I find that fat in front of the vertebral bodies, the longus coli and capitis musculature, and if a lesion is in the retropharyngeal space, it's going to be in front of that fat. It may flatten it or push it posteriorly. And if a lesion is arising from the perivertebral space, it's going to lift that musculature away from the vertebral body, helping me guess that that is in the perivertebral space. So there's a separate area. Prevertebral is going to be behind or inside of that musculature. Retropharyngeal space is going to be in front of that musculature. That's how we can distinguish those areas. So when I think about these cervical fascial layers and those fascial slips that define the neck into spaces, I don't personally think it's so important to memorize the fascial slips and which one has which name, but it's important to understand how they define the area into spaces. And then we can think about what anatomy normally lives in that space and make a space-specific differential based on the imaging characteristics. So anytime I have an extracranial head and neck mass, I try to think about where the thing is centered. Just like we talked about in the upper digestive tract, It may make a huge difference if you say a tumor is centered in the oral cavity than if it's centered in the oral pharynx. It's the same with all the deep spaces of the neck that are around the upper digestive tract. I'm going to think about how the mass interacts with either the parapharyngeal fat or the longus colli and capitis musculature. Then I'm going to assign a space origin to the lesion. And then I'm going to think about matching the radiologic features, either on CT or MRI, to a space-specific differential of what pathology happens to that anatomy in that space. So those deep cervical fascial layers define these different spaces. The parapharyngeal fat is very important for lateral suprahyoid neck masses. We want to remember that the pharyngeal mucosal surface or space is really where squamous cell carcinomas live. In the masticator space, we not only have the muscles of mastication, but you also have the mandible and the TMJ, and importantly, cranial nerve B3 at that location. We remember that the parotid space has the facial nerve going through it, and the pes anserinus, the goose's foot, as it spreads out through that area. There's another pes anserinus in the knee, but that's not important. Only the pes anserinus in the parotid space is important. In the carotid space, we remember that we not only have the carotid and the jug, but we have parts of cranial nerves 9 through 12, and we think about the lymph nodes associated with this area. In the retropharyngeal space, remember that we have fat in both the suprahyoid and the infrahyoid nodes, but we have fat and lymph nodes in the suprahyoid space. In the infrahyoid retropharyngeal space, we really just think about fat at that location. For the perivertebral space, we want to remember that those vertebral bodies are great nidus's for things like tumor and infection. So we want to think about the prevertebral and the paraspinal portion of the perivertebral space as that deep layer of the deep cervical fascia goes around the vertebral bodies and that musculature. And remember that we have the visceral space that really only exists in the infrahyoid neck. So we've got the larynx, the thyroid, the parathyroid, and lower the trachea and the esophagus below the cricoid at that level. So we have a lot of different ways to think about the anatomy of the extracranial head and neck and the cervical soft tissues. In pathology and in surgery and gross anatomy, we think about triangles, mostly centered around the omohyoid, the muscles going to the hyoid and the trap. But we can think about where that hyoid bone is and separate the neck into a suprahyoid and infrahyoid neck. And if we divide it up in that way on cross-sectional imaging, we can think about those fascial slips and layers in all these different spaces. And if we think about how the fat is affected, fat is your friend, it's very important in these studies. That's why the pre-contrast T1 is very important, sometimes more important than the post-contrast images. And when you start looking at a CT, it's really important to start off with a window level, something like 440, so that air is different than fat, because we want to think about this fat and how the fascial anatomy defines these spaces. Think about how the fat is pushed around, and then we can make a space-specific differential based on the imaging characteristics of pathology in the extracranial head and neck. And I thank you very much for your attention in this whirlwind tour through the fascial anatomy of the extracranial head and neck. Thank you very much.
Our second speaker comes to us from the Icahn School of Medicine, Mount Sinai West Hospital in New York, and that is Dr. Daniel Meltzer, who will be speaking on the topic of masticator and buccal space pathology.
Hello, my name is Dan Meltzer. I'm from Mount Sinai Icahn School of Medicine in New York, and I'll be talking about the masticator and buccal spaces. The main topics will be anatomy, mimics of pathology, infection, and neoplasm. And one of the key concepts is to watch for patterns of how disease spreads from one neighboring space to another. Starting with some of the anatomy at the higher part of the buccal space, I've indicated with the L, the lateral portion of the buccal space here overlying the masseter muscle, and the medial portion of the buccal space deep to the front of the masseter muscle. The arrows pointing to the muscles of facial expression, and the red arrow in the back here is showing you where the posterior boundary of the lateral portion of the buccal space is, where it meets up against the parotid space. This dashed line shows you the fascial plane between the buccal space anteriorly and the masticator space posteriorly. And sometimes this fascia is not complete, which will become important, as you'll see later. Here are the pterygoid muscles in the masticator space for reference, and also some of the adjacent fat in the masticator space, indicated by the asterisks. The long arrow on the other side of the patient is showing you the origin of the buccinator muscle, where it attaches on the posterior portion of the maxilla. This circle is indicating the facial vein. Now going a little bit more inferiorly, here again we have this red arrow pointing to the muscles of facial expression. The thin arrow is pointing to the parotid duct, which is coursing through the lateral portion of the buccal space and makes pretty much a right angle insertion into the buccinator muscle. The smaller arrow here is pointing to the buccal artery, which is a branch of the imax, part of the arterial supply to the buccal space. This arrow here is pointing to a structure in the masticator space. Actually, that's the tendon of the temporalis muscle attaching on the mandible. On the opposite side, this arrow is pointing to this little dot in front of the parotid duct. That's the the facial artery, and the circle is again showing you the facial vein. And now going slightly more inferiorly, I have this first arrow showing you the buccal mucosa next to the maxillary teeth. Then this curved line is showing you the submucosal fat, and just outside of that is the buccinator muscle. The yellow arrow is indicating the approximate location of an important structure that I'll talk more about later, the pterygomandibular raphe, which is within the retromolar trigone. And you can see here it's just in front of the triangular fat pad of the parapharyngeal space. I'll talk more about that too. This asterisk is showing you the buccal fat pad out in the lateral portion of the buccal space. That's variable from person to person and gives people their unique shape of their cheeks. In fact, here's a buccal fat fun fact. This portion is a form of adipose tissue called cysarcosis, similar to the orbital fat in form and function. It helps with motion of muscles like eating or nursing in babies. Now some more in buccal space anatomy going in the coronal plane. Anteriorly, here's the facial vein, this dot, muscles of facial expression. The fat arrow is pointing to the buccinator space. Going a little bit more posteriorly, sorry, the buccinator muscle, excuse me. Going a little bit more posteriorly now, we have again the buccinator muscle. Deep to that we have the submucosal fat plane that separates the buccinator muscle from the buccal mucosa of the oral cavity next to the teeth. This squiggly line out here is part of the fascial boundary lateral to the buccal space. It's in the same plane as the muscles of mastication. And this, on the opposite side, I'm showing you the parotid duct as it's about to insert into through the buccinator muscle. Masticator space anatomy now, starting more craniad. We have the masseter, the lateral pterygoid. Here's the pterygoid process. The T is showing you the temporalis muscle. And this arrow is showing you V3, the mandibular nerve. We're just below foramen ovale at this plane. And you can see it sits in this nice fat pad. Here's just to remind you, the buccal fat more interiorly, shown by the asterisk. Going slightly more inferiorly now, again, masseter. The medial pterygoid slants obliquely to join up with the angle of the mandible. This arrow is indicating the inferior alveolar canal for the inferior alveolar nerve. That's where it inserts. And the posterior portions of the mandible are part of the masticator space. So the angle, this groove where the inferior alveolar nerve comes off the V3, and the condyle and neck. Here now I'm showing you the parapharyngeal space, which is this triangular fat pad. You can see anteriorly it's rather narrow, and it doesn't form much of a boundary to disease. You can see it's situated between the oropharyngeal mucosal space and the medial pterygoid. Now on the coronal, this is a cross-section of the zygomatic arch. Here's the masseter. And the T's are showing you the temporalis muscle, which has a portion that goes up alongside the head into the suprazygomatic portion of the masticator space. Here's the medial pterygoid going down to the angle of the mandible. Lateral pterygoid, we see part of it heading toward the neck of the mandible. Asterisk is on the pterygoid process. And more posteriorly now, the lateral pterygoid is inserting on the neck of the mandible. Here's the medial pterygoid. This red arrow is showing you where foramen ovale is, and you can see this beautiful picture on this non-con T1 of V3, the mandibular nerve coming through ovale down into the masticator space, where one of its main branches will be that inferior alveolar nerve I mentioned. Here's the parapharyngeal space, this fat that's kind of narrow up top, just like it was narrow anteriorly on the axial. So moving on to mimics of pathology. The first one I want to talk about is accessory parotid tissue. Now this can be separate from the orthotopic portion of the gland, as you see on the patient's right side. And here it is on the fat sat T1, and then on the right-hand image I have T2. And on the same patient, on their other side, they also have accessory parotid tissue, but here it's contiguous with the orthotopic portion of the gland. In both cases, it follows the parotid duct, as you can see here. Here's the facial vein, that is probably the facial artery. Both structures are in front of the duct, anterior, and then anterior to that we have the facial muscles of facial expression. And here's that normal tissue on the patient's left side, continuous with the gland. It is normal parotid tissue. It should resemble parotid tissue on all imaging modalities in every sequence. As you can see, it can be separate or contiguous with the parotid. And it can mimic a node or a mass, even in the masseter muscle, if it's really asymmetric clinically on examination. And it should just look like regular parotid tissue, because it is parotid tissue. And because it is normal parotid tissue, it's susceptible to the same range of diseases that you can get in the parotid gland. Here's an example of a patient with an adenocarcinoma that arose in accessory parotid tissue. You can see it's probably invading the masseter muscle. Here's the here's the parotid space proper back here. So the next mimic I want to discuss is asymmetry of the pterygoid plexus. The pterygoid plexus is the main venous drainage for the masticator space, and it also has connections to the buccal space. These branches more or less parallel the IMAX artery branches. Here I'm indicating it with a circle, and they're eventually going to drain into the facial vein. So on imaging, they can look like this. They can be asymmetric, as you see in this patient's pterygoid muscles in the left-hand image. On the patient's left side, the yellow arrow is showing you. Venous anatomy is more susceptible to variation and asymmetry than arterial anatomy. Here's a different patient you can see in the lateral pterygoid. And more anteriorly, there's a little component that might be connecting to the buccal space, judging by where it is. And this is, once you see a few of these, you will not make this mistake. You just want to make sure you don't call this a vascular malformation or perineural tumor spread. Asymmetry of the masseter is fairly common. You see the patient's left masseter is enlarged on the CT. This is a different patient, also their left masseter enlarged on the non-con T1. This can be seen in patients who grind their teeth at night, so-called bruxism, or altered mechanics of chewing because of TMJ pathology. The important thing is that it otherwise looks just like normal muscle tissue. It's just bigger. And the final mimic that I want to discuss is denervation atrophy. So in the acute phase, as you can see, this patient's masseter and temporalis are enlarged, and that could be on, if that was on clinical exam, depending on the degree of asymmetry, that could mimic a mass. They're hyperintense on T2, they're enhancing, that's the acute phase. And in this same patient, they have some subacute denervation atrophy going on in their lateral pterygoid. More posteriorly, you see here, the muscle is a little bit heterogeneous. It's still enhancing a little bit, but it's beginning to shrink down. This patient had a giant cell tumor eroding foramen ovale. Once you get to the chronic phase, the muscles will be largely shrunken down and replaced by fat, as you see here. And if the normal side is felt to be asymmetrically prominent, that could mimic a mass if nobody knew what was really going on in the patient. For the rest of this talk, I am going to use green arrows to indicate the normal anatomy. And this was a patient who had asymmetric abnormal enhancement of the cisternal portion of their trigeminal nerve. It turned out they had neurosarcoidosis. So now I'm going to move on to talk about infection, specifically odontogenic infection in most cases. This is the most common source of disease in the masticator space, even though the teeth are not actually in the masticator space, they're in the oral cavity, and odontogenic infection can also affect the buccal space. So how does it get back to the masticator space if it doesn't start there? Well, it can track along the mandible, and if it turns laterally, it may go deep to the masseter, as you see in this cartoon. And corresponding to that, we have a patient with an inflamed masseter, and they had this abscess deep to the masseter. This was a patient who had extensive periodontal disease in their left posterior mandible. Or the disease process can turn medially and get into the pterygoids. And if it does go medially like that, it could go even further across those narrow anterior fat planes of the parapharyngeal space that I mentioned, and it can reach the pharyngeal mucosal space. So for example, here we have a patient with an abscess along the lingual surface of the posterior mandible. We're losing those normal anterior fat planes of the parapharyngeal fat, and we have abnormal thickening of the mucosal space of the oropharynx here. This patient had a recent tooth extraction, which was the source of infection in their left posterior mandible. And here's that green arrow showing you the normal parapharyngeal fat on the unaffected side between the medial pterygoid and the oropharyngeal mucosal space. Odontogenic infection can also come from the maxilla, in which case it's going to cross the buccal space and it can then go into the masticator space. So for example, here's a patient. You see the red arrow, we've lost those normal fat planes in the buccal fat, and all the fat planes between the muscles of mastication are obliterated. Here's the patient's normal buccal fat pad on the other side for comparison. This patient had extensive periodontal and endodontal disease in their left posterior maxilla. Here's another patient, a history of HIV, and comes in for cellulitis. You can see that the right maxillary sinus is socked in. You're losing those normal fat planes in the right buccal space. You're losing the fat planes between the temporalis and the medial pterygoid muscle more posteriorly. Here's the green arrow showing you the normal buccal fat. On the coronal image, again, we have the diseased buccal fat pad adjacent to the maxillary sinus. And this disease process is tracking superiorly into the suprazygomatic masticator space above the zygoma. And here's the green arrow showing you the normal buccinator muscle and buccal fat pad on the other side. That patient had odontogenic infection as well. You can see this erosion at the tip of one of the tooth roots in the posterior maxilla. Infection can come from other spaces. You see here in this cartoon, the parotid space is immediately posterior to the masseter. So corresponding to that picture, here's a patient with a large sialolith in the distal parotid duct, and they have a rip-roaring parotitis with inflammation of the adjacent masseter as well. This is less common. Otitis externa could secondarily affect the masticator space by crossing the parotid space first. So here we have a patient with disease in their external auditory canal, and they're developing an abscess in their parotid, and the infection is spreading further anteriorly to involve the masseter. This is less common. More typically see this in somebody with some kind of immunocompromise like diabetes. Here's a variant of that. A 7-year-old came in with temporal swelling. You can see this subperiosteal abscess along the posterior portion of the temporal bone, and there's swelling of the temporalis muscle overlying it. On the coronal here in the upper right-hand corner, you can see the soft tissue thickening in the roof of the membranous EAC involving the base of the pinna, and they had extensive disease in their otomastoid complexes that was thought to be the source of this. Infection can also come from the pharyngeal mucosal space. So, for example, this is sort of the reverse of something I showed you earlier. In this case, the infection's arising in the pharyngeal mucosal space, going laterally across those anterior fat planes of the parapharyngeal space to involve the pterygoids. So this patient has a classic peritonsillar abscess. You see this rim-enhancing fluid collection. We've lost the normal fat planes between the oropharynx and the adjacent medial pterygoid muscle. Here you can see on the coronal again, here's the abscess. The yellow arrow is showing you where you've lost those parapharyngeal fat planes, and there's inflammation of the medial pterygoid. And the green arrow is showing you the normal parapharyngeal fat between the medial pterygoid muscle and the oropharyngeal mucosal space. And here's another patient with a peritonsillar abscess on their right side. And why am I showing you two of the same thing? Well, because this patient had another thing on the unaffected side, at least not acutely affected. They have this soft tissue mass with what looked like phleboliths in it. And so it turned out they also had an incidental venous malformation on the other side. And venous malformations are commonly found in the masticator or buccal space. They can involve either space or both, as I was saying. Here's a patient, a different patient. You can see it's T1 intermediate. There's some patchy enhancement. Some of the areas don't enhance, and they also stay dark on T2. Those are probably phleboliths. And I'm going to just use this topic of vascular malformations as a sort of segue before I go into talking about neoplasms. Here's another patient, a 6-month-old male with a intermediate to bright mass involving their buccal and masticator space. There's a little flow void along the medial aspect, and this is an infantile hemangioma. And this is actually a really good segue to talk about neoplasms, because this is a vascular malformation, but it also is a benign neoplasm. It's classified as a neoplasm, hemangiomas. So, neoplasms in the buccal space. Tumors of salivary origin are most common, and I did show you that adenocarcinoma arising in the accessory parotid tissue early on in the talk at the lateral aspect of the buccal space, but I'm mainly going to be discussing minor salivary gland tumors a little bit later, as you'll see. Nodes exist in the buccal space. They can be involved by various neoplasms. I showed you a hemangioma, that's going to be pediatric mainly. And you can have lymphoma or less common tumors of mesenchymal origin occurring in the buccal space. So let's just go on to some examples. 49-year-old with a right facial mass. The green circle is showing you that submucosal fat between the buccal mucosa in the oral cavity and the overlying buccinator muscle. And the minor salivary glands live in that submucosal fat, and they excrete their saliva into the mouth to help us eat. And you can see on the other side that that fat extends up high, even above the teeth a little bit, deep to the buccinator muscle. So now, technically, you could make an argument that anatomically we're not talking about the buccal space now, because the minor salivary glands are deep to that buccinator muscle, which kind of forms the boundary between the oral cavity and the buccal space. But I'm going to just consider that a technicality, because minor salivary glands are a common source of neoplasm in the buccal space. You see here this red arrow showing you where we've lost that submucosal fat, and you have this intermediate signal mass extending laterally into the buccal space. And on that same patient, on the right-hand image, it's a T1 fat set with contrast. You can see the enhancing mass in the medial aspect of the buccal space. We felt like it was not invading the buccal space at this time. It does look like it's coming right up against that fascial boundary that I indicated earlier. This was an adenoid cystic carcinoma. Buccal space malignancy can get into the masticator space so very easily. It can go posteromedially, or it can go laterally. So I'll show you an example. This is a 61-year-old with left facial vein. The green arrow first to show you the normal buccal fat, then the yellow asterisk showing you the mass in the left buccal space, and you can see it involving the pterygoids, and going laterally to involve the masseter. In the coronal CT image on the right-hand side, I have the green arrow showing you the normal buccal fat, and the yellow arrow showing you this mass, which has some little calcifications. Here it is on the post-contrast fat set T1, heterogeneously enhancing, involving the masticator space here, and also the masseter laterally. This was an adenoid cystic carcinoma as well. And this is that same patient. I've just blown up that coronal image for a second. I want to point something out. So here's the main mass, partially calcified again. And you see this little component down here looks separate. This is probably an enlarged lymph node of the buccal space. And then on follow-up 3 months later, you can see they still look kind of separate, and that node is hugely enlarged and getting necrotic. And this brings me to an important anatomic sub-area I just want to mention, the retromolar trigone. This is the non-tooth-bearing mucosa along the posterior maxilla and mandible. And this white circle that I'm indicating on the cartoon is a structure called the pterygomandibular raphe, and it's being caught in cross-section here. It's a fibrous band where the buccinator attaches, and so does the superior pharyngeal constrictor muscle. And the raphe runs from the skull base, it attaches to the pterygoid annulus, down to the mandible. So if tumor gets on there, it can go up into the skull base or down into the masticator space. This is just a photo. You can see where the pterygomandibular raphe would be roughly back here behind the teeth, more or less. So here's an example of somebody who had tumor involving their retromolar trigone. You can see it's right up against the medial aspect of the buccal space on this CT. It may be involving the medial pterygoid back here in the masticator space. And here's that heterogeneous enhancement on the fat set post-contrast T1. Here's another patient. I've circled the tumor. It's in the medial part of the masticator space, probably involving the back of the buccinator muscle here. Here's the green arrow showing you the unaffected side with the posterior portion of the buccinator muscle coursing posteriorly, where it's eventually going to hit the pterygomandibular raphe roughly in this area. On that same patient, here's the coronal showing you the enhancing mass up against the lateral posterior portion of the maxilla. Basal cell adenocarcinoma in this case. This is a 90-year-old with facial pain and trismus. They have this homogeneous bulky mass going from the medial aspect of the buccal space through into the masticator space, and it's eroding the posterior portion of the maxilla around the roots of this tooth. The green arrow showing you the normal buccinator on the unaffected side. Here's that erosion of the tooth on the coronal. Again, the green arrow showing you the normal buccinator muscle. And here's another separate component, this ovoid soft tissue here, again, very homogeneous, intermediate density, probably an enlarged lymph node. This was the patient with lymphoma. Here's a destructive mass centered where the maxilla used to be with some floating teeth in it, involving the nasal area anteriorly and going back into the muscles of mastication. It's involving the pterygoids here. The green arrow shows you the normal fat pad of the buccal space. Here again, you see medially involvement of the nasal cavity, laterally involving the buccal space, and they had some necrotic lymph nodes in the submandibular triangle. This was squamous cell carcinoma, likely arising from the maxillary sinus. Another patient, left-sided facial pain and mass centered in the maxillary sinus, going through the posterior lateral wall, across the buccal fat to involve the temporalis muscle, and same findings on the coronal. This was also squamous cell carcinoma from the maxillary sinus. This patient is a 17-year-old, came in with fullness. You can see the replacement of the marrow in the posterior mandible on the affected side. Anteriorly, it's involving the buccal space. All the normal landmarks in the masticator and buccal space are gone by this T2 intermediate mass. On the right-hand image, you can see it invading the masseter and pushing it laterally, pushing the medial pterygoid medially, likely involving the opening of the inferior alveolar canal, as the red arrow is showing you. So this mass was involving the buccal and masticator space. This was a rhabdomyosarcoma, and I'm going to use this as a segue to talk a little bit more about masses that arise in the masticator space proper. So benign tumors, you're generally going to be talking about schwannomas. Primary neoplasm of the muscle is rare. Non-Hodgkin's lymphoma can arise in muscle or bone. Malignant tumors are frequently going to be sarcoma. So here's an example of a schwannoma. We're just below foramen ovale. You can see this ovoid mass on the patient's right side. And on the coronal, you can see it widening foramen ovale and extending from the Meckel's cave area down into the masticator space. These get more heterogeneous on T2 and on T1 post-contrast. As they enlarge, they start to have some areas of cystic breakdown. On the patient's unaffected side, you can see the green arrow indicating V3, the mandibular nerve, beautifully demonstrated here, this curved line going down towards the inferior alveolar canal. And back on the left-hand image, the green arrow is showing you V3 on the normal side, just below foramen ovale, sitting in that fat pad of the masticator space. Here's another example. It's getting more heterogeneous because it's large, involving the cellar region, going through foramen ovale into the masticator space. This patient actually had an additional schwannoma in their IAC. It turned out they had NF2. Non-Hodgkin's lymphoma can arise from bone or muscle. Here's a mass destroying the posterior mandible. You can see it involving all the muscles of mastication on this image, even anteriorly getting into the buccal fat. On T2, it's intermediate, and it has some restricted diffusion, as we would expect for small round blue cell tumors. Here's another example of a non-Hodgkin's lymphoma, and I included this second example because it reminds us of another neighboring space. The lateral portion of the orbit is just next to the suprazygomatic portion of the masticator space. This tumor is in the suprazygomatic portion of the masticator space. You can see it infiltrating the bone of the sphenotemporal buttress and abnormal enhancement in the lateral portion of the orbit. Again, it's intermediate to dark on T2. This is a classic chondrosarcoma with the whorls and arcs of chondroid matrix. Here there's an intracranial component. The whorls and arcs will be darker on T2 because they're mineralized and will not enhance as much. Here's a patient with metastatic disease. They had a history of thyroid cancer. You can see this erosion of the opening of the inferior alveolar canal where that main branch of V3 goes in, the inferior alveolar nerve, as opposed to the green arrow showing you the normal CT hypodense fat that we would expect on the unaffected side. And on the T1 image on your right, you can see that abnormal low signal of the fat in the opening of the inferior alveolar canal. They presented with right-sided chin numbness. The green arrow showing you that normal T1 bright fat on the unaffected side. The patient had a history of thyroid cancer. Metastatic disease can rarely affect the muscles of mastication. This is a 96-year-old with trismus. They have a history of lung cancer, and they have abnormal enlargement of their left pterygoid, temporalis muscle, and also of their medial pterygoid muscle, shown in the right-hand image on their other side. Tumor can also come from the nasopharynx, just like I showed you with infection earlier, coming from the oropharynx and going laterally across those narrow anterior fat planes of the parapharyngeal space to get into the muscles of mastication. And on its way there, as it crosses these narrow fat planes of the parapharyngeal space, it could cross the path of V3, the mandibular nerve. So here's an example. We have some normal fat planes in the right masticator space and also at the right foramen ovale, the unaffected side. And on the other side, we have this T1 intermediate mass crossing from the nasopharyngeal space laterally. We've lost those fat planes in the masticator space through the abnormally widened foramen valley into the left Meckel's cave area. This was a nasopharyngeal carcinoma. And perineural spread of tumor, the main mechanism for it to get intracranially from the masticator space is along V3. And as you can see in this cartoon, the patient has a mass involving the medial aspect of their mandible, lower down. There's abnormal thickening of V3, the mandibular nerve, all the way up through foramen valley into the Meckel's cave area. And this image nicely corresponds, I believe, to that diagram. You can see there's abnormal thickening of V3, the mandibular nerve, from its all the course that we can see in this image from where it gets to the inferior alveolar nerve, all the way up through the masticator space, through foramen valley to Meckel's cave. This patient had a history of a prior adenoid cystic carcinoma of the submandibular gland. So, today we covered pseudo-lesions. We talked about asymmetry of the pterygoid plexus, masseter hypertrophy, denervation atrophy. We talked about acute, subacute, and chronic. And we saw some examples of accessory parotid tissue. We talked about odontogenic infection coming either from the mandible or the maxilla. We discussed primary and secondary malignancies of the buccal and masticator spaces, and also we talked about metastatic disease. And of course, one of the key concepts is that the main mechanism for perineural tumor spread to get from the masticator space intracranially is along the mandibular nerve, V3. And we saw some involvement of the buccal space and the masticator space by disease processes from some of the other neighboring spaces like the parotid space and the pharyngeal-mucosal space. And we also talked about the retromolar trigone. Thank you very much for your attention.
Our third speaker, Dr. Mokan, comes to us from the University of Illinois at Chicago and will be speaking on the topic of parapharyngeal and carotid space pathology.
And I'd like to first thank the program committee and program chair, Dr. Schmalfuss, for giving me the opportunity to talk to you about two of my favorite spaces in the neck. I'll try to take you on a journey into the parapharyngeal and carotid spaces, full of food and fun. You'll see. Let's start with the parapharyngeal space. But before we plunge into the space, there is a terminology issue that I need to mention. When you're talking about parapharyngeal space, what you mean may not be the same with somebody else. Furthermore, there are additional terms such as prestyloid parapharyngeal space and poststyloid parapharyngeal space, which might complicate the issue. So let's look into those terms. This is my favorite sequence. It's a post-contrast fiesta sequence, delineating the relevant anatomy. When a otolaryngologist is talking about parapharyngeal space, she means this entire area in the deep neck. However, we as radiologists, we can somewhat make things easier for us by dividing the space into two. That will allow us somewhat easier differential diagnosis. We can do this separation by using a natural facial plane that extends from the posterior aspect of the tensor veli-palatini muscle, extending posterolaterally and inferiorly to the styloid process and styloid muscles. And that's our fascia, and it's called tensor vascular styloid fascia. The TVS allows us to separate the parapharyngeal space into two compartments, the prestyloid parapharyngeal space and the poststyloid parapharyngeal space. We can actually further simplify things for us by calling that prestyloid parapharyngeal space the true parapharyngeal space and the poststyloid parapharyngeal space as the carotid space. And that's the terminology I will be using for the rest of this talk. The parapharyngeal space is a space unique to the suprahyoid neck levels. It is, as you can see, surrounded by all the remaining spaces. On the axial images, it is seen more like a rounded lobular area. However, actually, it is more like an inverted pyramid that is better seen on the coronal images. This is a very deeply seated space in the neck, and that's why the lesions in this space can easily reach large sizes before becoming symptomatic. And they need to reach 5 or 6 centimeters in size in order to be appropriately palpated beneath the angle of the mandible, and that's why they can be clinically very difficult to examine, and that's why we as radiologists play a very important role in lesions of this location. As you can appreciate on the signal on any MR image or the density on the CT images, this space mainly contains fat. However, it can also have vascular structures, nerve branches that course through it, in addition to ectopic rest of minor salivary glands. And of course, the lesions of the space will arise from those contents. And you'll see lipomas of different shape and size. And you can also frequently see vascular anomalies here, as illustrated in this case of a venous vascular anomaly with internal phlebolytes extending from the peripheral space to the parotid space. Or as in this case, that was histopathologically diagnosed as hemangioma, but probably we can agree that this is more likely to be a venous vascular malformation with internal phlebolytes, as you can see here. Additionally, you can of course see minor salivary gland tumors and peripheral nerve sheath tumors. They can actually look quite alike. The more important issue is to make sure that these lesions are completely surrounded by fat. Because, believe it or not, very few lesions are really truly primary to that space. So you really need to see the lesion completely surrounded by the fat in order to accurately place it into the space. The more frequent lesions are actually lesions coming from the surrounded spaces and kind of protruding into that space. So we have to use that fat signal at fat density in order to characterize the or determine the location of the mass. If it is completely surrounding the mass, then yes, it is a primary peripheral space. But if it's displaced, then that displacement will tell you the source of the mass. So in this space, the fat is definitely your friend. Probably the most frequently seen mass you'll see in this location will be masses arising from the deep lobe of the parotid. And you can see why. The deep lobe of the parotid really protrudes into the peripheral space. And as anywhere in the body, when you have a growing tumor, they tend to grow towards the path of least resistance. And when you have this bad pill of soft fat, well, they grow into it and they can reach quite considerable sizes. And they can also, and they will show displacement of the peripheral space or fat anteromedially. So whenever you see a large mass in this location showing this medial displacement of the peripheral space, look to the lateral edge of it and see if you can see the extend into the parotid gland. Even if it's not extending into the parotid itself, but you do not see a separate fat planes, you can assume that this is indeed coming from the deep lobe of the parotid. As in this other case, again, a pleomorphic adenoma displacing the peripheral fat medially. You might wonder, well, we know what this is, we do frozen and then we determine that this is a pleomorphic adenoma. Why does it matter whether we tell that it's primary peripheral or coming from the deep lobe? Well, it matters to the surgeon, because if they know that this is a primary peripheral mass, then they can access this tumor and resect it with a transcervical approach. However, if it's coming from the deep lobe of the parotid, they might need to do a transparotid approach in order to preserve the facial nerve. So the extra versus intraparotid origin will really determine the surgical approach. Furthermore, not always the FNA gives you appropriate results, and they're not always easy to biopsy. For example, this was a very unfortunate mucoepidermoid carcinoma reaching considerable size in this location before being diagnosed. Lesions in the adjacent mucosal surfaces of the visceral space can also grow into the peripheral space, as in the case of a nasopharyngeal carcinoma, displacing the peripheral fat anteriorly and laterally, and a tonsillar carcinoma displacing the fat laterally. Similarly, lesions in the masticator space can easily extend to the peripheral space, but then we will see medial displacement of the peripheral space, as in this case of a spindle cell carcinoma in a 17-year-old, or a rhabdomyosarcoma in a much younger person, again displacing the fat medially. Thankfully, we don't only have neoplastic processes in this that do this. More frequently, we'll see infections extending from the mucosal surfaces, such as tonsillar tissue, into the parapharyngeal space, and you can see reticulation or dirty fat in the parapharyngeal space, or even extent of the tonsillar abscess into the parapharyngeal space itself. You don't need to always have an abscess. This was also an infection extending to the parapharyngeal space from the mucosal surfaces, and this was caused by a very small and innocent fishtail. Similarly, infections in the masticator space can extend to the parapharyngeal space and displace the parapharyngeal fat medially. And in most of the masticator space infection, usually the culprit is somewhere around the mandibular or maxillary teeth. So the take-home message for parapharyngeal space is that the fat is your friend. Look for the displacement of the fat to accurately determine the source of the mass. Let's move to the posteriorly located space, the carotid space. The carotid space is seen both in the suprahyoid and infrahyoid levels of the neck. It extends all the way from the skull base to the aortic arch, and you can see it as like two parallel columns extending throughout the neck. And sometimes the carotid space is used synonymously as the carotid sheath that is surrounded by all three layers of the deep cervical fascia. However, structures such as lymph nodes and sympathetic ganglion that are outside of the carotid sheath are still included in the carotid space. A few anatomical helpful findings. Again, you can see that the parapharyngeal fat is anteriorly located to the carotid space. The styloid process would be typically lateral located, and the posterior belly of the digastric muscle separates the parotid from the carotid space, and it can help you differentiate a parotid mass from the masses in the carotid space. What are the contents of this space? Common and internal carotid arteries will be seen in this space, depending on the level you're looking at. Internal jugular vein will extend throughout it, and several cranial nerves are seen in this space. The vagal nerve extends throughout its course, but the additional cranial nerves kind of enter a little higher into the carotid space, so they are only present in the upper levels of the carotid space. As mentioned previously, sympathetic plexus and lymph nodes, although they are outside of the carotid sheath, they are in the carotid space. Of course, the lesions of the space will be related to those contents, and you'll see related lesions. However, the most frequent ones will be the peripheral nerve sheath tumors and the paragangliomas. Let's start with the paragangliomas. Paragangliomas, or glomus tumors, are typically benign, highly vascular neoplasms, embryologically originating from the extraadrenal paraganglioma of the neural crest. They are frequently associated with recognizable genetic defects of succinate dehydrogenase enzyme. It has been now established that up to 35% of head and neck paragangliomas have defects in this SDH enzyme. Glomus tumors tend to be multifocal, even in sporadic cases, but especially in the familial cases. And depending on their size and location, they can either present as an incidental finding or they can cause numerous neurological symptoms, such as neck masses, dysphagia, upper in the neck. They can cause pulsatile tinnitus and so forth. More importantly, they are very, very highly vascular tumors. That's why no head and neck surgeon in her or his right mind would like to biopsy those. So you play a crucial role in diagnosing those cases. They always remind me of this kind of a big and plump raspberry ready to burst, or a rubber band ball kind of ready to jump, as they are basically large tangles of vessels. Because of that high vascularity, they will show this robust EVID enhancement on the CTA and CT neck width contrast, and again, they can be bilateral as demonstrated here. On MR, related to that vascularity, they'll have those little T2 hypointense appearances due to the flow voids. They can also have little foci of T1 shortening due to the presence of hemorrhage, giving us the so-called salt and pepper sign. And again, you can appreciate the enhancement on the post-contrast images. If you do a time-of-flight MRI, you may not see any increased signal. However, on the contrast-enhanced MRI, they will show avid enhancement similar to the adjacent arteries even. And this characteristic can also be used in terms of differential diagnosis. If you perform a dynamic contrast-enhanced MRI, it can allow you to appropriately diagnose those conditions. This dynamic features can also be used in the setting of a 4D time of result MRI, where the lesion will show early fill-in and washout. Pregangliomas are named according to their location in the neck. And as you can see, they are most common in the level of the carotid bifurcation, where they are called carotid body pregangliomas or glomus caroticum. These are, again, will present as slowly enlarging, usually asymptomatic, deep neck masses with or without pain. And because of their association with the carotid artery, they are laterally mobile, but rostrocaudally fixed. And this is a helpful feature for a clinician usually. On the sagittally formatted images and on the DSA, they create this typical so-called layer sign. And as you know, that those lesions are typically cause of a brute on auscultation, that name is really appropriate. When they are small, they are typically more or less homogeneous. However, as they increase in size, they start having internal heterogeneity and necrosis. It is crucial to correctly diagnose those cases, but your job is not done by just naming those or correctly diagnosing them. You have to give the shambling classification. The only curative treatment for glomus caroticum tumors are surgical resection. However, this can be frequently associated with neurological morbidity after surgery. And the shambling classification is basically a predictor of this morbidity. It helps us and the surgeon to counsel the patient accordingly. If the tumor does not cause any displacement of the internal or external carotid artery and does not surround the vessel, it's a type 1. However, if it's causing displacement and surrounding either of the vessels more than 270 degrees, it's a type 3, which is associated with a much higher morbidity. The only other glomus tumor I will include here, as these are the only two included in the carotid space, is the vagal pregangliomas or the glomus vagales. These are much rarer tumors, a little more frequent in women, but they are frequently associated with multiple cranial neuropathies, cranial nerve 10 being the most frequent one. And the reason is the vagal preganglia are a little bit different than the remaining preganglia, as they don't really form discrete and separate bodies, but they are incorporated within the nerve itself underneath the perineurium, hence causing more frequent neurological findings. They have the imaging features that are already discussed, avid enhancement on CT, salt and pepper sign on MR with, again, avid enhancement. And you can see the enhancement and increased signal on the contrast enhanced MRA. This was a 63-year-old male who was getting an MRI for hearing loss, and this lesion was incidentally detected. Upon further investigation and assessment for his for this mass, he was found to have actually another one at the carotid bifurcation. So he not only had a glomus vagale, but also a glomus caroticum. And that's an important take-home message. You know, whenever you see a lesion that looks like a glomus tumor, start looking for additional ones, because you will frequently see additional ones in the neck. As in this case, for example, again, they can also be seen, for example, in the middle ear at the level of the jugular foramen. And those, when they are in those locations, they tend to be small and easily missed. Another important feature regarding those lesions is that they can also be malignant. That malignant potential is variable. It is reported to be slightly more frequent in vagal pregangliomas. Unfortunately, there isn't really a good imaging criteria and even no good histological criteria to differentiate benign from malignant lesions. And the presence of metastasis is the only reliable indicator of malignancy. That's why, again, whenever you see a mass that looks like a glomus tumor, make sure you look at the lymph node in the neck. Make sure you look at the bones at the included levels to make sure there aren't any metastases. All right. So in addition to paraganglioma, the other common lesions here are the peripheral nerve sheath tumors, and schwannomas are probably the most typical example. These again arise, of course, from the Schwann cells, and they are somewhat more frequent in patients who are in their 30s, 40s, and 50s. Although they can present with different symptoms, the most common presentation symptom is just a painless neck mass. They are seen as well-circumscribed, enhancing masses, and of course, as they increase in size, they tend to have more internal cystic degeneration, especially when they're homogeneous. On the post-contrast images, they can show this avid enhancement and can sometimes fool you thinking that this could be a glomus tumor. However, if you have a contrast-enhanced MRA, that's very helpful. I particularly like CTA or a good CT neck without too much delayed contrast injection because it really is helpful ruling out a glomus tumor. No glomus tumor in its right mind would show this kind of enhancement. Actually, this has been recently published. The authors have described something called light bulb sign that should help differentiate glomus tumors from other lesions in the carotid space. However, just as a side note, something that can look like glomus tumor on the CTA and contrast of enhanced soft tissue of the neck are metastases from papillary thyroid carcinoma as well as renal cell carcinoma. They can be quite hypervascular and can show similar enhancement pattern to the glomus tumors. What other features do we see in schwannomas? So schwannomas that we see in the carotid space are frequently vagal schwannomas. And as you can see, the vagus nerve is posterior and somewhat in between to the internal and common carotid artery. So as you have a tumor growing in this location, it will typically displace the carotid arteries anteriorly and intermediately, and at the higher levels, you will also see this kind of splaying of the internal carotid artery from the jugular vein, as you can see here. How about this case? You know, a well-circumscribed lesion in the distal carotid space, homogeneously enhancing. What could it be? Is it a schwannoma? Well, the internal carotid artery is laterally displaced, which is somewhat unusual for a vagal schwannoma. Could that be a glomus tumor? Although glomus vagale would also displace ICA anteriorly. Let's see the CTA. No, definitely not a glomus tumor. Then what is that? Well, it's still a schwannoma, just not a vagal schwannoma. As you can again see on that diagram, the sympathetic chain, although it's not in the carotid sheath, but it's in the carotid space, is medial to the vascular structures of the carotid sheath. So when you have a tumor growing in this location, it will tend to push the internal carotid artery laterally or posterolaterally. And again, if you have those two different kind of schwannomas side by side, you can see that the sympathetic schwannomas will displace the ICA posteriorly and laterally. However, vagal schwannomas tend to displace them anteriorly and medially. And further on, you should be seeing the splaying of the ICA and internal jugular vein as well. How about neurofibromas? They are frequently associated with NF1, but actually they are most commonly seen as solitary lesions in the neck. They come in two forms in the neck, deep neck, either localized or plexiform. Of course, if you have a plexiform neurofibroma, that is diagnostic of NF1. Regardless of the type, they will show this hyperintense T2 sign, well-delineated margins, and furthermore, another helpful sign called the target sign. This is not a sign unique to neurofibromas. It can also be seen in schwannomas, but it's more common in neurofibromas. Another helpful feature is their contrast enhancement characteristics, showing, not so much enhancements like dirty appearing enhancement on the post-contrast images and little, if any, enhancement on the CT images. You can again ask me, why does it matter? It's a benign lesion. Why do I need to differentiate this from a schwannoma? As you can see here, schwannomas will typically displace the nerve fascicles. However, neurofibromas infiltrate between the nerve fascicles, so you cannot really take this tumor out without sacrificing the nerve. And that's why many of the deeply seated neurofibromas will not be surgically excised and will be often managed conservatively. Let me show you another challenging case. So you have a distal carotid space mass, somewhat homogeneous on T2, but maybe a few flow voids. avidly enhancing on the post-contrast images, and as you can see, it is extending to the skull base and even intracranially. So it looks a little funny. Could this be again like a glomus vagale? Definitely not. It is not. And actually, the answer is on this image with this dual thickening and enhancement. And it is an extracranial meningioma. Extracranial meningioma, although rare, can easily extend into the distal crevasse space and should be considered within the differential diagnosis of the lesion you see in this location. All right, in addition to those tumors, of course, we can see lymphadenopathies, benign or malignant lymphadenopathies, as in the cases of lymphoma in 2 different patients, and of course, HPV positive oropharyngeal carcinoma metastasis on this one at the bottom. And sometimes they can be challenging. Let's look at this case, for example, very avid enhancement. It kind of looks like a glomus tumor on this image, but the helpful feature is that the ICA was displaced laterally, and in a vagal glomus tumor that should have been displaced anteriorly. Furthermore, there were very similar appearing additional lesions in lower neck, proving that those were metastases, and this one was actually secondary to a medullary thyroid carcinoma. And this one was actually not in the carotid space. This is in the retropharyngeal space, retropharyngeal lymphadenopathy displacing the carotid laterally. This was also a somewhat difficult case of a lesion in the distal carotid space, very homogeneous, avidly enhancing and displacing the ICA anteriorly. Is that a vagal schwannoma? This patient had a history of prior treatment for lymphoma, and although she was in remission, she was presenting with new symptoms. She also had a PET CT demonstrating very avid SUV uptake in this location, and this was further on proven to be lymphoma. So, of course, things can look similar, but you have to use all your additional tools to appropriately diagnose those cases. And we'll finish by talking about the vascular lesions that can occur in the space. Internal jugular vein lesions, thrombosis, and thrombophlebitis can be seen, and usually you can diagnose them relatively easily by the kind of fusiform expansile appearance, and usually the culprit is on the images, as in this case of indwelling catheter, but they can also be seen in secondary to prior surgery or trauma. And presence of retropharyngeal edema is usually a helpful feature. Carotid lesions can, of course, be seen in the space. Dissection is a good example with T1 shortening related to the periluminal thrombus in this case. Aneurysms can present as expansile masses here. This was a patient with a large carotid aneurysm who had been treated with a covered stent, and you can see the displacement of the submandibular gland. The one on the left is a patient who had been treated for head and neck carcinoma with radiation treatment and came into the ED with abundant bleed, and you can see the pseudoaneurysm in this on the left side, unfortunately. The last topic I'm going to be mentioning is another kind of vascular lesion called keratodynia, and it's a pain syndrome, basically, diagnosed when the patient has tenderness and pain at the level of the carotid bifurcation. It is diagnosed when there is no underlying other conditions, no neoplastic process, no underlying systemic inflammatory granulomatous conditions, and it typically quite quickly responds to steroids and non-steroidal anti-inflammatory drugs. The terminology has been recently discussed, and there is a new suggested term for it called the Tippich syndrome, transient perivascular inflammation of the carotid artery. Whether or not this is really a separate entity or something within that umbrella of inflammatory conditions of the neck, it's again a controversial issue, but you can definitely suggest this diagnosis if you have focal soft tissue thickening and enhancement at the level of the carotid bifurcation, either on MR or CT, without any underlying condition and with the appropriate presentation of the patient. Okay, we have covered the spaces, parapharyngeal and carotid spaces of the neck, and as promised, I tried to show you a few fun stuff and definitely some food. And of course, remember, fat is your friend, at least in the neck. Thank you.
Our fourth speaker, Dr. Karen Salzman from the University of Utah, is a professor of radiology and imaging sciences, the chief of neuroradiology, and the director of the Neuroradiology Fellowship Program. And she's going to be speaking to us about the intricacies of MR physics as they apply to K-space, what every neuroradiologist needs to know for head and neck imaging of the K-space. Actually, she's not. She's going to be talking to us on the topic of the nasopharynx.
Good afternoon. First, I'd like to thank the organizers for the invitation to speak today. My name is Karen Salzman. I'll be speaking about the nasopharynx, anatomy, and pathology. I am a consultant and book author for Elsevier. So the outline for the lecture today is to talk about the nasopharynx anatomy, looking at the landmarks, as well as the fascia, and then spend the majority of time looking at the various pathologic lesions that occur in the nasopharynx. These include infectious inflammatory lesions as well as neoplastic lesions. We'll spend a fair amount of time talking about the nasopharyngeal carcinoma, which is the most common neoplasm of the nasopharynx. So let's start with anatomy. So the nasopharynx is really a part of this big tube known as the pharynx, made up of the constrictor muscles, superior, middle, and inferior. And it's a continuous mucosal surface. The pharyngeal mucosal space or surface is the area that we're dealing with. The nasopharynx is at the top, and it's along the posterior aspect of the nasal cavity, seen here. It's separated from the oropharynx at the level of the hard and soft palate, seen here. And then the oropharynx continues inferiorly as the hypopharynx. You can see in this sagittal T1 weighted image in a normal patient, the nasopharynx present superiorly, and we can see the other anatomic landmarks. So anteriorly, we have our nasal cavity. Superiorly, we have the floor of the sphenoid sinus and the clivus, and then also this cranial-cervical junction posteriorly. So the nasopharynx is surrounded on its deep margin by the middle layer of deep cervical fascia, seen here in pink. And this surrounds the entire pharynx. Posterior to the nasopharynx, we have the retropharyngeal space, and then laterally the parapharyngeal space as this fatty space. So let's look at some of the important nasopharynx anatomy. The lateral pharyngeal recess, or fossa of Rosenmuller, seen here with this yellow arrow, is probably the most important space for you to recognize because it's the location where the vast majority of nasopharyngeal carcinomas arise. Lateral to that, demarcated by the green arrow, is the torus tubarius, which represents the cartilaginous end of the eustachian tube. The pink arrow shows the eustachian tube opening, and then we have important muscles of the nasopharynx, which are important for staging. Along the lateral aspect, here we have the levator veli palatini muscle, and that is again superficial to this middle layer of deep cervical fascia outlined here in pink. And then more laterally, we have our tensor veli palatini muscle here. The superior constrictor muscle is present posteriorly, demarcated here, and again, it's very important as it forms this pharynx tube. This diagram nicely demonstrates the retropharyngeal tissues posteriorly, and the blue line is the deep layer of deep cervical fascia, and then laterally we have our parapharyngeal fat, which is important for staging. Typical normal anatomy of the nasopharynx, we have our lateral pharyngeal recess, our fossa of Rosenmuller, seen here in in yellow, the green demarcating the eustachian tube, torus tubarius, and then the opening to the eustachian tube in pink. And on the coronal image, we have that same view. We have this lateral retropharyngeal recess. Note how close it is to the skull base, and then also our torus tubarius in green. In an older patient on MR, we can see these structures again, the yellow representing this lateral pharyngeal recess, and in this case, the mucosa is collapsed. On the opposite side, it's filled with a benign retention cyst, so it nicely kind of opens that space. The green is marking the torus tubarius, and then the opening to the eustachian tube is noted here in pink. In this young patient, we can see that there's a lot of normal adenoidal tissue. However, we can still see these landmarks. We have our fossa of Rosenmuller, our lateral pharyngeal recess, and then our torus tubarius in green. So this skull base view shows how the nasopharynx interacts with the skull base. So the nasopharynx is seen here in blue. We have important structures here. We have the basisphenoid. We have that sphenoid bone anteriorly, the sphenoid body, and then more posteriorly, the basiocciput made up of the occipital bone, and along the posterior margin, the clivus. So the foramen lacerum is a really important structure. It doesn't have any cranial nerves coursing through it. However, it does allow nasopharyngeal carcinomas to extend superiorly into the skull base. And it's a cartilage surrounded space adjacent to that horizontal internal carotid artery canal. The pharyngeal-basilar fascia I wanted to mention, it's seen here demarcated by this black line, and it's really just a tough aponeurosis that connects the superior constrictor muscles to the skull base. And it's important in that it actually also helps allow the spread of nasopharyngeal canal or nasopharyngeal carcinoma superiorly, but also it's important to remember there's actually a gap within that, or a notch, posteriorly within the pharyngobasilar fascia called the sinus of Morgagni. And although we can't see it, we know it's there because it also allows the levator palatini muscle and the eustachian tube to pass as they course from the skull base to the pharyngeal mucosal space. But this also allows nasopharyngeal tumors to spread laterally from that sinus, from the nasopharynx into that parapharyngeal region. And the reason I mention this fascia, again, the fascia we can't see, but we know it's there, and it's important because it is a relative barrier to the spread of tumor and infection to other spaces in the deep face. So let's look at a little more nasopharynx anatomy. This pink layer just shows this middle layer of deep cervical fascia, which is present throughout the entire pharynx. The things within the nasopharynx include mucosa, and that's where the majority of neoplasms arise, squamous cell carcinomas, known as nasopharyngeal carcinomas in the nasopharynx. There is the lymphatic ring throughout the pharynx, and at the level of the nasopharynx, the adenoidal tissues can give rise to non-Hodgkin's lymphoma. Minor salivary glands are present throughout the pharynx, and it can be seen here, drawn in, just as these small salivary rests that can give rise to both benign and malignant minor salivary gland tumors. The pharynx goes from the skull base to the hyoid, and as I've mentioned, nasopharynx superiorly, oropharynx in the middle, and then hypopharynx inferiorly. So let's start looking at some of the various pathologies that occur in the nasopharynx. We'll cover both congenital developmental lesions as well as infectious inflammatory lesions and how to differentiate those from neoplasms, and then spend the majority of time looking at neoplasms. This is just a classic example of a nasopharyngeal mass. If you ever see fluid in the mastoid air cells, and I want you to notice this on every case, whether it's a head CT for headache, or a sinus CT, or a brain MRI for altered mental status, you really want to look, if you have this fluid, you always want to look at the nasopharyngeal mucosa, look at that lateral pharyngeal recess, that fossa of Rosenmuller, to see if there's a tumor, because you can help diagnose tumors early this way. This is an obvious large tumor of the nasopharynx with extension anteriorly into the nasal cavity. So let's look at the Tornwald cysts. These are benign developmental midline cysts. They occur in the midline nasopharynx classically. They are a notochordal remnant, so I've drawn this yellow line showing you the course of the notochord. And this is important for these lesions, but as well a more important lesion that you may see, which is a chordoma, which also occurs along the notochordal remnant. Tornwald cysts are usually asymptomatic and incidental. They're reported in about 5% of normal brain MRIs. And this is what they look like. Seen here in the sagittal view, we have this small cystic lesion right at the nasopharynx. It's T1 hyperintense in this case, but they have variable signal, typically fluid signal. On this T2 weighted image, it has both hyperintensity and low signal intensity within the lesion right in that midline nasopharynx. Notice there's no invasion. The prevertebral musculature is nice and normal. And these are typically asymptomatic, but occasionally they can get very large, particularly if they get infected. They can have periodic symptoms like halitosis and unpleasant taste in the mouth. Retention cysts are pretty common. These usually occur in the lateral pharyngeal recess and that fossa of Rosenmuller, as in this example. On this T2, you can see it's hyperintense and just fills that lateral pharyngeal recess. But importantly, post-contrast, there's no associated enhancement, because then you'd be worried more about a carcinoma. Additionally, these generally do not result in eustachian tube dysfunction, and there is no fluid within the mastoid air cells. Here's another patient with a more ovoid retention cyst, and this has peripheral enhancement but no enhancement within the center. And these again have variable protein content and no enhancement. Here's another example of a nasopharyngeal retention cyst. This one is T1 hyperintense. It fills that lateral pharyngeal recess or fossa of Rosenmuller. And on the post-contrast image, you see that the cyst itself is non-enhancing, but we see normal enhancement about the adjacent mucosa along the lining of the nasopharynx. Lymphoid hyperplasia is something that you will commonly see, typically in children or young adults, usually less than 30, or in HIV positive patients. What happens is there's hyperplasia of the adenoids, palatine, and lingual tonsils, and importantly, it fills only the pharyngeal mucosal space with no infiltration of the adjacent tissues. Also, it's typically symmetric and bilateral, and often there are inflammatory lines on post-contrast imaging. This is a young patient who was imaged for headaches, 18-year-old, who has just prominent adenoidal tissues. You can see that the adjacent structures are nice and normal. The prevertebral muscles are clean. We actually see some of our normal anatomic landmarks, our torus tubarius here. And this is a different patient with HIV. You can see there's marked hypertrophy of the adenoidal tissues filling this nasopharynx, and also in this case, a small cyst in the parotid, likely a lymphoepithelial cyst. The main thing that we're worried about differentiating this from is lymphoma. Here's another patient, a young patient who has both lymphoid hyperplasia in the nasopharynx, completely filling that space, and also reactive lymphadenopathy in the retropharyngeal lymph nodes. On post-contrast imaging, we nicely see these inflammatory septations as lines throughout typical lymphoid hyperplasia. Here's another patient, a child who has post-contrast imaging nicely demonstrating these inflammatory septations as these lines related to lymphoid hyperplasia. And again, we see just nice, clean margins. The prevertebral musculature is normal, and so that helps differentiate this from a more malignant process. We're going to switch gears and start talking about tumors of the nasopharynx. We're going to start with nasopharyngeal carcinoma, which is the most common tumor that we'll see of the nasopharynx. These classically arise in this lateral pharyngeal recess, as in this case. They are strongly associated with EBV infection. MR is really the way to stage these tumors because it very nicely identifies the extension into the parapharyngeal space fat, the skull base infiltration, which is really common, as well as the intracranial tumor. A lot of times these patients present with lymph node metastases, approximately 90%, and the lymph nodes typically go to the retropharyngeal lymph nodes as the primary drainage, and then also levels 2 and 5. Here is a classic example of a nasopharyngeal carcinoma with extension anteriorly into the nasal cavity. This is the AJCC tumor staging, the 8th edition. I put this here for your reference, and I'll highlight a few things that are different and interesting, and that I wanted to make sure you're aware of. So the 8th edition added this T0 tumor stage, which is really interesting to me. It's basically no evidence of a primary tumor by imaging, but these are the patients who get biopsied with lymphadenopathy. They have EBV positive lymph nodes, no evidence of a primary tumor, and these are presumed nasopharyngeal carcinomas. The other thing that's a little bit different in particular is this T2 tumor. T2 is now tumor that extends to the parapharyngeal fat as well as the adjacent soft tissues. So if you have infiltration of the medial and lateral pterygoids or the prevertebral musculature, it remains a T2 lesion. And just with T staging of all head and neck squamous cell carcinomas, the higher the T stage, the more invasive. So nasopharyngeal carcinoma comes in two major varieties, either keratinizing or non-keratinizing, and rarely there are basaloid squamous cell carcinomas. The keratinizing nasopharyngeal carcinomas are those that have similar risk factors as for other head and neck carcinomas, squamous cell carcinomas, and include tobacco, alcohol use, and these are often associated with HPV. In North America, it represents about 20 to 40% of nasopharyngeal carcinomas, and usually these patients present with locally advanced disease. Non-keratinizing nasopharyngeal carcinoma is the most common of all nasopharyngeal carcinomas. These are highly associated with EBV infection. These tumors are endemic in China and Southeast Asia, and they also come in two varieties, the differentiated and the undifferentiated. And the vast majority of non-keratinizing NPCs are undifferentiated tumors. Here's a typical T1 MRI example of a nasopharyngeal carcinoma. We have a large mass along this origin in the lateral pharyngeal recess. It is extended posteriorly to invade the adjacent structures, including the musculature, the prevertebral musculature, and then laterally it's gone through the middle layer of deep cervical fascia into the parapharyngeal fat. Nasopharyngeal carcinomas can occur at any age, but the peak incidence is between 30 and 60 years. Patients usually present with bloody nasal discharge or epistaxis. Often they present with a lymphadenopathy as well as serous otitis from a eustachian tube opening. The survival is reasonable for the non-keratinizing with a 5-year survival of 75%. Keratinizing nasopharyngeal carcinomas have a much lower survival rate of about 20 to 40%. And interestingly, the prognosis is better if you have an EBV positive tumor. Here's a classic example of a keratinizing nasopharyngeal carcinoma, a 65-year-old male with risk factors of tobacco and alcohol use. And we have a large tumor in the left nasopharynx, which is resulting in a small fluid in the mastoid air cells related to eustachian tube dysfunction. There's also lateral extension into the parapharyngeal fat. The nasopharyngeal carcinoma staging is really clinical staging, and it's important to remember nasopharyngeal carcinoma is non-surgical disease. The vast majority of patients are treated with radiation therapy as the primary therapy. Surgery is really just reserved for persistent or recurrent disease. This is a graphic that shows the typical spread patterns of a T4 lesion, starting in the nasopharynx and extending laterally into the various spaces, parapharyngeal and masticator space, and then posteriorly into the prevertebral musculature. This is a 24-year-old patient with an EBV positive nasopharyngeal carcinoma. It's an extensive tumor that extends posteriorly to the prevertebral musculature, laterally through the parapharyngeal fat and into the masticator space. And we have the large positive lymph node in that retropharyngeal location. And this is the first order drainage for nasopharyngeal carcinomas. Here's another example. I highlight this case because it's just a patient who comes in with evaluation for sinusitis. And I want to alert you to every patient, take a look at those mastoid air cells if there's an effusion, and even if there's not, look at the nasopharynx. In this case, this nasopharyngeal carcinoma was caught early on this non-contrast sinus CT done for sinusitis. And he does have a little mucosal thickening, so definitely has some sinus disease, but much more important is that this nasopharyngeal carcinoma was caught much earlier than it might have been. Here's another example of a nasopharyngeal carcinoma. This is a 43-year-old male. There's fluid in the mastoid air cells, so we're looking at our nasopharynx, and we see this mass that's filling this fossa of Rosenmuller here. Post-contrast, we see that it's enhancing diffusely. This is just the torus tuberous. Here's the contralateral torus tuberous on the opposite side. And we can see this is a nasopharyngeal carcinoma. This is the same patient, this 43-year-old. And even though the tumor was relatively small, there's positive metastatic lymphadenopathy noted on the PET, although it looks relatively small on the MRI. I put this case in to illustrate the fact that nasopharyngeal carcinomas are quite FDG avid and that PET CT is very useful in the initial staging of these tumors. Here's another example of a nasopharyngeal carcinoma. This shows this large tumor filling the nasopharynx, extending into the nasal cavity. And then a little more inferiorly, we have the tumor extending inferiorly, and then we see this pathologic lymphadenopathy in the retropharyngeal lymph node, the first order drainage for nasopharyngeal carcinomas. Here's another tumor. This is a 39-year-old with the nasopharyngeal carcinoma. This one is a little more bilaterally noted, filling pretty much both sides, but clearly originating in this enlarged nasopharyngeal recess, lateral recess, this fossa of Rosenmuller. In this case, this PET also shows the lymphadenopathy pathologic in the retropharynx, as well as the deep cervical chains bilaterally. Here's another patient. I put this case in. It was actually referred to neurosurgery at the University of Utah because they thought it was a chordoma. And what we have here on the CT is this large posterior soft tissue mass at the level of the nasopharynx. We know we're nasopharynx because we see our nasal cavity here. We have fullness here in this 44-year-old patient. The prevertebral musculature looks a little suspicious, and on the sag flare, you can see it looks almost like it could have started in the clivus. So anytime you have this central skull-based mass, I want you also to consider, could this be a nasopharyngeal carcinoma? In this case, we see that it's heterogeneous. There's mass effect on the adjacent pons. And you can see that it has invaded the clivus as well. This is the axial and coronal image on that same patient, and this is very typical appearance of a nasopharyngeal carcinoma and not a chordoma. It was also not hyperintense on T2, which would lean you more towards chordoma. This shows classic imaging of a nasopharyngeal carcinoma. We have this large enhancing mass in the fossa of Rosenmuller and nasopharynx extending anteriorly to the nasal cavity, laterally into the parapharyngeal space fat, and posteriorly into the prevertebral musculature, and partially encircling this horizontal internal carotid canal. We also see that there's bony invasion of the clivus with enhancement in the entire right clivus on this image. And then this coronal view nicely illustrates the typical spread pattern of these nasopharyngeal carcinomas. Because of that tough pharyngobasilar fascia and the middle layer of deep cervical fascia, these tumors often extend superiorly into the skull base, as in this example. And we see this large, bulky tumor with extension superiorly through foramen lacerum and also into Meckel's cave, where the trigeminal ganglion lives. So let's switch gears a little bit and talk about other neoplasms of the nasopharynx. Non-Hodgkin's lymphoma is the second most common malignancy of the nasopharynx, and these can sometimes mimic nasopharyngeal carcinomas. These are extranodal non-Hodgkin's lymphomas. They tend to be B-cell lymphomas, but T-cell lymphomas can also occur here. And these occur because there are three subsites of Waldeyer's lymphatic ring within the pharynx. At the level of the nasopharynx, we have the adenoids, and then at the level of the oropharynx, we have the palatine and lingual tonsils. These non-Hodgkin's lymphomas typically present as large pharyngeal mucosal masses with associated cervical lymphadenopathy about 50% of the time. There's a higher incidence in AIDS patients, patients with Sjogren's, Hashimoto's, IgG4 disease, as well as autoimmune conditions. Here is a typical patient showing this non-Hodgkin's lymphoma tumor in the right lateral nasopharynx, looking just like it's filling the fossa of Rosenmuller with relative sparing of the prevertebral musculature. Here's another patient with a classic lymphoma of the nasopharynx. The T1 shows diffuse involvement of the nasopharynx, and this is a 72-year-old male, not a 17-year-old, and therefore there should not be any normal adenoidal tissue at this point because as you age, your lymphatic tissues decrease. So we have this huge mass in the posterior nasopharynx. We can tell it's not normal because it's invading the prevertebral musculature as well as the adjacent bones. So we have osseous involvement of the clivus. The post-contrast shows this diffuse enhancing mass, again invading the prevertebral musculature and the right aspect of the clivus involving that occipital bone. This sagittal CT on the same patient just nicely illustrates this nasopharyngeal mass, which you may see on your CT done for other reasons. And in this case, you can see this invasion superiorly into the clivus and into kind of the basisphenoid and basi-occiput with associated invasion. So nasopharyngeal lymphoma is something also to consider with a large enhancing nasopharyngeal mass. The other thing that can be particularly helpful in lymphoma, regardless of where the lymphoma occurs, whether it's skull base, head and neck, brain, is diffusion imaging. And diffusion is extremely helpful in lymphomas because it often shows diffusion hyperintensity on your trace image with low ADC values. So this nicely illustrates in the same patient this diffusion trace hyperintensity with low ADC values, which is classic and typical for nasopharyngeal lymphomas and other lymphomas of the head, neck, and brain. So let's look at benign mixed tumors. These are rare tumors. They occur from minor salivary gland rests. The soft palate is the most common location for benign mixed tumor in the pharynx. These are well circumscribed enhancing masses as seen here. This one is filling the lateral nasopharynx and the posterior aspect, reaching the posterior aspect of the nasal cavity. These can be differentiated from other neoplasms in that there is no invasion of the adjacent structures. A malignant salivary tumor, on the other hand, also arises from these minor salivary gland rests and can occur anywhere within the pharynx. These are enhancing masses which do have invasion of the adjacent structures. Lymph node metastases are uncommon with salivary gland tumors as opposed to the typical nasopharyngeal carcinoma, which almost always presents with metastatic lymphadenopathy. The common tumors of the salivary glands, the malignant ones, the most common would be adenoid cystic carcinoma, as in this example. We can see this large central mass within the nasopharynx in this young patient, 32-year-old. It's invading the prevertebral musculature in this example. Other malignancies that can occur in the nasopharynx arising from these salivary gland rests include mucoepidermoid carcinomas and adenocarcinomas, but these are more common in the oropharynx. This just shows additional imaging of that same patient, showing this large mass in the nasopharynx with enhancement and invasion of the prevertebral musculature in this patient with an adenoid cystic carcinoma of the nasopharynx. So in summary, we have reviewed the key anatomic landmarks. It's important to remember the middle layer of deep cervical fascia and that the most common location to look is your lateral pharyngeal recess. The last highlight I want to remind you is that if you have a mastoid effusion, look at your nasopharynx. Please identify these nasopharyngeal carcinomas early. And with that, I will thank you so much for your attention.